yeah, this week I will buy like external hard because my storage is already gone. So if it is converted, I will upload in the YouTube. Okay, don't ask me like I'm not like keeping hide it. Okay, because there's no need of doing that. Otherwise, I'm not doing the session, right? Yeah. So I'll try if it is like converting because usually it's storing the Zoom. Then after converting to my laptop, that is something process ongoing. So if it is converting, then I can. Otherwise, it is stuck and it can't convert. They are like sending like unable to convert or something like that. And I'm just thinking of doing session for August doctors. August doctors, special like especially for August doctors, like some workshop or something, like discussing each like as much as we can, like the high yield topics, not like 2 to 3 hour session, just like 4 to 5 hour session. I'm just thinking about it, but still not yet confirmed. Okay, if I'm doing it, I will make a separate group and I will do it. Okay, yeah. So for start this one, right? I was just thinking, okay? Not sure, but if I have time, I will do it. Okay. So here, okay. What do you know about CT? So we have two types of CT, right? Non-contrast CT and contrast CTs, right? So where are we using this non-contrast CT, right? So non-contrast CT, why we are using? It's quick and widely available, right? No IV access needed. Detect many important abnormalities. Just like a general idea. Okay, I will quickly go through because that also somewhat helpful. Avoid contact risk, right? Allergies, nephropathies, and often first test before the contrast study, right? Most of the cases. So in we can use for the CT of the brain, right? Renal pathology, chest or abdomen, muscle, skeletal pathology, we can use it, right? So, yeah, when we should consider contrast CT doctors. So, when we should consider, like, if you need like a better visualization, right, to characterize the masses and lesion, to assess the abscess, infection extent, to evaluate the vascular structure, to stage imaging, right? When non-contrast CT is inconclusive, in those cases, we are going with the contrast CT, right? Contrast CT. So that is very important. So non-contrast CT. If it did like some cases, if you need like a better visualization, no, like the non-contrast inconclusive, in those cases you can use this contrast CT, right? Okay, so what are the contrast CT we are using? Some media, right? Some media, some fluid that we use to administer, then we are taking the imaging, right? So what are the common CT contrast we are using? Iodinated contrast, right? That contain iodine and high atomic number. And usually we give IV, most commonly oral or rectal, right? And other than oral or rectal, you can give, right? This is for the CT scan, angiography, IV contrast studies, right? So here, um, yeah. So, why contrast used to improve the visualization of the structures, right? Can you see this is poor differentiation without contrast, but with contrast, you can have the better visualization, right? And like, what are the major risk factors that you are using contrast? There can be allergic reaction, right? Or there can be a contrast nephropathy. Because of that, we are avoiding the contrast using imaging in CKD patients, right? Especially if it is less than 30, right? So those are the general idea that you need to understand. So today I'm explaining mainly the CT abdomen and some pathologies from the pelvis as well. Okay. So here, so before starting the CT, okay, and other than that, I need to explain about, not explain, I will tell you about like when considering the contrast CT, we have three different phases, right? Arterial phase, portal venous phase, and delayed phase, right? So what is arterial phase? That means early after, early just after we are giving the IV contrast, right? Because in that case, you can see the arteries enhanced like very brightly. So for we are using the arterial phase usually to understand the vascular pathology, right? If there's active bleeding ongoing, some leaking happening, in those cases we are using arterial phase. That is not important. Just listen, okay? It's important, not for us, like mainly for the radiologists. Okay. So then portal venous phase. Usually it is after the later, right? Later we are using it. Sorry, doctor. No. This is my PDF. So later we can use. We are using the portal venous phase. Usually we are using that for to visualize the portal vein system and the abdominal solid organs, right? Because you need to look at those walls, right? Those things. And the delayed phase, like after several minutes, but in those cases, the contrast start to accumulate, like usually useful for like understanding UT, like urinary tract lesions, those things. Okay, that's what just if you don't need to remember, but for the like get the general idea. Okay, the general idea. Okay, so yeah, and CT, we have different planes, right? We are given different. We have the axial plane, right? This type of CT we call axial plane because this is the most commonly used CT. The body is visualized horizontal, slice from head to feet. It's like a slice you are seeing, right? Here, image from the patient's feet looking upward. Patient in the right, appearance on the left side of the. Okay, just to assess this, like remember this picture. Okay, I'm not going to explain too in detail. Doctor, I told you earlier I have some storage problem. I have not sorted it out. I'm just recording, but I'm not sure is it stored in the Zoom or in my laptop converting not or not. If it is converting, I will upload. Okay. I told you because otherwise I will do because I have to buy some external storage this this week before the exam week. I couldn't sort it out. Okay. So don't ask other questions. I'm just explaining this. Okay. So we have CT plane, axial plane, mostly used. Then we have coronal plane. This one, right? Coronal plane. View from the front, right? Divide the body into anterior, posterior sections. Then here you can see this kind of CT. Okay, I will explain. Doctors, please keep your mic muted. Or because I'm also not a very expert in those radiology. Okay, I'm not expert. I'm also just learn to teach you. Okay, I took a lot of time to prepare these slides and everything. And I went through all these guidelines and everything and the e-medicine to teach you. Okay, so because of that, you should respect me, right? So keep your mic muted and because I'm also like doing everything for you, especially for the August doctors, so you have to respect them as well. Okay, this is the coronal view, and you have the sagittal view. View that mean you are looking it from the like a side view, right? Right to right and left half, like here. You are cutting half into the body, then you are seeing like this. Okay. So this is the three planes that we are getting in the exam. I'm so sure you have noticed the pictures that they have given in the e-medicine, right? Yeah, yeah, doctor. Yeah, there should be respect, right? Yeah. Okay, because I'm also doing a huge work here, right? Yeah, okay. So then you have to a step wise you have to interpret this CT, right? We call it A, B, C, D, E, F, and G, right? This is the way of interpreting, right? So A mean what? You are looking for the air, right? Air. So you are looking for free intraperitoneal air present or pneumobilia, right? Portal venous gas present. So you need to check for air. This is the easy way to interpret the CT, right? A. B mean you can assess the bowel, right? Wall thickness, how the bowel fiber present, the dilation, right? Transient transition point, especially in the mechanical obstruction, right? Is there an obstruction? Is there any dilatation without mechanical obstruction, without transition point? You have to make sure you know everything. Oh, the perforation, present ischemia, right? You have to check the bowels. Then you have to check for the collection, seam in collection. That means you can look for the abscess, free fluid, the hematoma, right? Those things. Something has collected, you have to check. Then D mean digestive organs. You have liver, gallbladder, pancreas, spleen. You have to check for the digestive organs. Then E mean other than like, everything else, right? Like kidneys, adrenal gland, urinary bladders, pelvic organs, those lymph nodes you have to check. At E mean the free fluid, right? Ascites, blood O that's present. Like G mean the greater vessels like aorta, inferior vena cava, mesenteric vessels you have to check. Okay, this is the easy rule, simple rule. So black air, dark gray fat fluid, right? Gray soft tissues, and white you can see bone calcium contrast. Okay, I will give a better one. Okay, remember like this. Okay, air, it present as black, right? So fat tissues, dark gray. Okay, so if it is fluid, like dark gray to black, right? Dark gray to black. Then if it is soft tissues, you can see it from as like a gray, right? I will explain, okay, from different one. Then this is a general rule. Then contrast like blood vessels, you can see the high bright white, right? Bright white. So bone and calcified, like they are very high bright than these blood vessels, right? Than these blood vessels. If it is metal present somehow, like after nails or something after like fractures or those things, you can see the brilliant white, right? Brilliant white like that. Okay, that is general idea. Okay, why this is not loading? Okay, then we will discuss about the normal abdominal CT. Normal one, then we'll come back to the pathology. So normal here, this is the axial view. So you can see the liver, right? You can see the liver, the gallbladder, right? And here the inferior vena cava. Okay, here inferior vena cava, then portal vein here. So stomach here you can see. Stomach here, the pancreas, you can see the body tail, right? Then splenic vein here. Then the spleen is here, and you can only see here the left kidney, right? Left kidney. So like just keep in mind, because I just can explain like these are the organs that present in like this, but you should remember, right? You should remember. Actually, you can do the like the questions, and like you can identify the pictures in the internet, and on that time like you can revise it, like this is the liver, this is the gallbladder. You can like revise those things actually by doing the question. That is the best way I can tell you. Okay, here yeah, and here this is other another picture. Here liver, the gallbladder, can you see like the relation? Liver is here, the gallbladder, and you can see the pancreas. Pancreas is like a small worm, right? A small worm. And usually, I'm always telling in the classes, like if there's a pancreatitis present, remember this worm is getting swollen, right? The swollen worm-like appearance, right? If it is a pancreatitis, the inflammation present, okay, like that. Then here abdominal aorta, then here inferior vena cava, right? Left kidney, the spleen, right? Because according to the angle and everything, like the area of we can see that can be changed, right? So here you can clearly see the spleen, right? Left kidney, like that. So this is the way that you can find a lot of images in the Google, okay? And like don't try to use AI generated CTs or like X-rays, because the thing is they are not properly given. Always try to get from the Google. Okay, Google image. You can type as example normal anatomy, axial CT abdomen. Then you can find it out, because like once they are generating the pictures that we are using, um they can do the mistake. Okay, you can try it, and then you can understand what is the difference. Please use the images that they have given in some research papers, articles, or some not in the Google. Okay, and e-medicine, yeah, like that. I don't know about Gemini doctor. I'm just telling, because like these are imaging, right? Imagine that actual body parts are going. So because of that, use true images. Okay, these are all from the all I got from internet. Okay, internet, different articles, those things. Because I have noticed, because I compared when I asked to. When I try to generate one picture, and they are marked it wrong way. That's what I'm telling, okay? Because I tried, because before that I won't tell you, because most of doctors like nowadays using AI to generate the notes, very it's very good, right? Easy way to remember, but like for these kind of things, don't use, okay? Yeah, because there can be a problem here. So again, another one here, liver, you can see the gallbladder. I'm just showing these things because in different pictures you can see different things, right? Here, then here's the linea alba, here the stomach, here the left lobe of the liver, the gallbladder here. The understand the relationship, right? If it's the gallbladder, if it's the liver here, the gallbladder should be there, right? And here the falciform ligament, right? The round ligament, and the stomach here, the splenic flexure here, the pancreas here, always like a worm, right? And what is the inferior vena cava? Here, you can see the adrenal gland, right? From the top of this right kidney here. Can you see hepatorenal recess here? Then ribs and everything they have mentioned. The spinous process, spinal canal, T2 vertebra here from the level of T12. Sorry, T12 vertebra, aorta also here, left kidney also. You can in this level, this angle, you can see the properly the right and left kidney, right? The spleen also very visible, right, doctors? So like there are so many pictures you can find it internet, okay? And here, okay, now try to okay, okay, just 1 minute. It has gone. I have to open it again. Sorry. Okay, no, this one. Okay, okay. Okay, now I'm going to, okay. Uh, Tell me what is number one. Don't look at the right side. Don't look at the right side. Don't look at the right side. Just tell me what is number one. Mm-hmm. Okay, then what is number four? What is number four? Inferior vena cava, right? What is number five? Aorta, right? Okay. What is number six? What is number six? Number six, psoas muscle, right here. The level matters, okay? Here. Okay. Yeah. So you will understand. Okay, you will understand once we are doing it. Okay. Yes, six psoas muscle. Okay, here. Okay, and we'll get a better idea about these muscles as well. Not very important, but here. Here you can see the psoas muscle, right? Psoas muscle. And here, okay, so rectus abdominis here because this is very important. Once you are doing rectus sheath hematoma, right? Rectus abdominis muscles is very important here because this is the area that you can see the rectus sheath hematoma, right? Then here external oblique, then internal oblique muscles. You can see the transverse abdominis, right? Psoas muscle, right? Quadrus lumborum muscle. Then, yeah, here latissimus dorsi also present in erector spina muscle, right? The psoas muscle is very important. The rectus abdominis is very important because sometimes they are asking from the psoas abscess, psoas hematoma, right? Because of that, that is very important. Okay, so here, okay, let's this. I couldn't find. Oh no, this picture better. Okay, this picture better for the coronal view. Okay, here, can you see? Anterior posterior view. Okay. So you can see esophagus, aorta, right? And here you can see the liver, right? Under the liver, here you can see the area, the right kidney, and here the psoas muscle, right? Both psoas muscle are very clear in here. The left kidney, right? And here you can see the stomach, and here the spleen, right? And small intestines, you can see the descended colon here and here, right? And the appendix in this area. Okay, so here. Then small intestine, the bladder, prostate, seminal vesicles, like everything is very clear because this image, actually the colors are like somehow someone is colored in the, I got this from the internet, Google. Okay, so very clearly you can understand. Okay, very clearly you can understand. But the axial, what is it? There's a no difference, doctor, the level, because sometimes they are given like the given like psoas abscess, right? Psoas muscle abscess or psoas muscle hematoma. Because of that, you need to know the where's the psoas muscle in the axial CT, right? And you need to know where's the rectus sheath hematoma because you need rectus sheath muscle because then only you understand where's the rectus sheath hematoma, right? Inside the muscle, right? Like that. Okay, so that is what. Like, this is the general normal anatomy. Okay, normal anatomy, no pathology in here, just anatomy. And the sagittal view. Sagittal view, you can see the stomach and here the liver, the about the diaphragm, right? And the spleen here, the left kidney, because this is like a cross section, not the cross actually, the right or left side of it, right? And the transverse column, the jejunum, ileum, descending column, right? Because you can see the bowels here, right? The stomach, the liver, and the spleen here, the left kidney, like that. Here, again, this is a normal one, okay? Here the liver, the diaphragm here, right ventricle here, the stomach, transverse colon, jejunum, ileum, those things. Okay, and here the uterus and bladder also it mentioned. Yes, be very familiar with these images, right? Then only you will understand. Otherwise, like once you, it's like you have not studied this CT earlier, and you just saw the picture and you will be confused. Oh my God, what are those things? What are these things, right? There can be a lot of things. Okay. When looking at any city, you have to ask these questions yourself. Well, this is like a general idea, okay? So don't be like, don't go to memorize those things. I'm just explaining because this way you can easily understand. Is it bigger? Then it's a dilatation or enlargement. It is a thicker inflammation or tumor. Is there any fat strand in? Present, is there any free air or fluid present, is there any transition point, right? Is the contrast enhanced normal, like that. Okay, so here, okay, if you want you can take a screenshot. This is like a general idea, okay, general idea. So if the because once you see a fat stranding around the those organs, what it can be, there can be inflammation around that related organ, right? Because that is very important you to understand. Fat stranding, then wall thickening can be seen in inflammation, infection, edema, or tumor as well, right? If there's a luminal narrowing, this narrowing present in where the chronic inflammation or tumor causing obstruction, right? This narrowing or some like strictures, right? Then bowel dilatation in obstruction, right? Transition point in the mechanical obstruction, right? Transition point, very important. That day also I have explained when I was doing the bowel obstruction session, right? So that is very important, the transition point and collapsed distal bowels that confirm the mechanical obstruction. Then free intraperitoneal air, the bowel perforation, very important. I will show pictures. Okay. If you see free intraperitoneal air, you have to suspect there's something perforated, right? Perforated. Then free fluid inflammation, perforation, or sinusitis, right? Then fluid collection within the enhancing wall, that is abscess, right? So, if there's a poor absent enhancement, there can be bowel ischemia, right? Pneumatosis intestinalis, gas within bowel wall, then bowel ischemia. Very, I will show, okay? Not like this. You can very clearly see in like small dots, like small bubbles, like in the wall of the bowel, okay? It's very important. Then, if you can see the portal venous gas, there can be a bowel ischemia here. Fat stranding, very important. The wall thickening, the narrowing stricture. Anyway, it's easy. You can understand the bowel dilatation. You can understand your transition point, very important because when you should considering those functional obstruction from the mechanical obstruction, because functional obstruction they don't have any these physical physical obstruction, right? Because of that, there's no T point, there's a no transition point, right? Because of that, those are very important. And the free intraperitoneal are very important. There can be a perforation, right? Those things can be present. Okay, yeah. Okay, so the other things. Okay, so according to the hypodense, if you want doctors, you can take a screenshots. Okay, I can't tell every time. Just you can take it if you want. There's no restriction or anything because yeah. Otherwise, after this, I'm going to some family gathering and I'm not available for like few hours. Because of that, I can't send a screenshot or anything from here. Okay. So here CT appearance according to the density, according to the density of the lesion, how you should decide. If it is simple hypodense lesion with thin walls and fluid density, you can see a benign cyst. Okay, if it is a hypodense lesion with thick ring enhancement, you can see the abscess. Right, so hypodense with surrounding fat strand in inflammatory lesion, right? So once you see the fat strand, you think about something inflammatory, right? Inflammatory lesion. So the hypodense wedge-shaped lesions, there can be infarction. Multiple hypodense lesion, there can be metastasis. I will show, okay? And yeah, then hyperdense acute blood or calcifications. So heterogeneous lesions, necrosis or tumors or trauma, right? A rim enhanced lesion, very important, like abscess, right here, like thick rim enhancement, you can see the abscess. Multiloculated cyst within the daughter cyst is typical for hydrogen cyst, right? The daughter cyst. Fluid collection adjacent to the pancreas, you can think about the pseudocyst, okay? Pseudocyst. Okay, so we'll discuss some things. Actually, for like small bowel obstructions and the large bowel obstruction, they usually give X-rays. Okay, I have explained everything about X-ray in the bowel obstruction session. Then I told you I will explain CT finding in here. Okay, so because this is very important, that usually we are diagnosing it from the initial X-ray, right? But some cases you need to go with this CT as well. So mechanical obstruction. So here CT findings, you can see the dilated small bowels more than 3 centimeter, central bowel loops, transition point, collapsed distal bowels, multiple layer fluid levels, right? Okay, I'll show here. So here small bowel. So these are the things you can see. Let's discuss. This is from the Life in the Fast Lane. Okay, I had to went to a lot of guidelines to gather information. If you want, you can type a small bowel obstruction, LIFT, Life in the Fast Lane. You can find this one. Okay, here the degree of dilation can vary based on the severity and acuity of the obstruction, but in general, when the small bowel loops are greater than 2.5 to 3 centimeter in diameter, an obstruction become likely. Okay, it is helpful to remember that normal small bowel may have some fluid or even slightly dilated loops or two. However, normal small bowel does not have that tense, crowded appearance of many dilated loops, and it's seen within the obstruction. Can you see the dilated loops here? Is a normal one, and this is the dilated loops, right? This is from the Life in the Fast Lane, okay? Okay, why not? Okay. And they have mentioned about the transition point. As you are following dilated small bowel loops through the abdomen, look the tapering of angulation. This indicates the transition point where the small bowel change from dilated obstruction loop to normal decompressed loop, right? So the transition point, that is the point that this obstruction is started right here. Can you see the transition point? Here the transition point, the obstruction, right? The basically the obstruction, the mechanical obstruction point, right? Identify the transition point, carefully evaluating the area will help to determine the cause of obstruction, whether it's adhesions or more complex causes like a mass or hernia or closed loop, right? Here's the transition point. Transition point, okay? Here's the transition point. Here's the transition point. Okay, so then you can see the fecalizations. So fecal matters you can see in this appearance. Yeah. This refers to the content of the small bowel taking on the appearance of stool like feces, which is characterized by little black dots of air. Very important, like little black dots of air. Those are the fecal materials, right? Normally, the contents of small bowel
Doctor,
fluid
please
like.
show the last image. Dr. Sithara, please show the last image.
Sorry, doctor. Sorry, doctor. I can't hear you properly. Can you repeat? I don't know what. Okay. Okay, please, if you know, if you have any doubt, like we'll discuss later. Okay. First, we'll discuss the session. Okay, so here you can see like this appearance, right? Okay. And here the fecalization normally occurs right before the transition point, and identifying it can help direct due to the cause of obstruction. Fecalization occurs because of the bowel contents have remained stationary over the time. The water content become reabsorbed, causing the content to take the appearance of stool, right? So keep in mind this thing. Okay, what? I don't know, doctor. Okay, here. Then the large bowel obstruction. So that day we have discussed the types of large bowel obstruction, right? We have got colorectal cancer, sigmoid volvulus, cecal volvulus, right? The diverticular stricture, closed-looped LBO, inflammatory stricture, extreme compressions, right? Fecal impaction, those things can be present, right? So we'll discuss. So yeah. Okay, okay. Can you show the last slide? Okay, I didn't hear you, doctor, because I have like reduced the volume here. Because of that, I didn't hear it properly. Okay, I thought, yeah, 1 minute. Okay, but if you have something, you can just type in the chat, right? Then it will not have a problem with like the continuous of the session, right? So last slide, I don't know why it is not loading. Okay, so this is the last slide I explained, and this is the other one, fecalization. Because I'm not going to explain everything in this file, okay? Because we need to do it quickly. Okay, so yeah, colon cancer. So that is a one of more main important thing that you need to understand. Let's see. But I got those things from the eMedicine. Okay, so what are the points? Because eMedicine pictures are very important. Okay, very important. Why? If you have time, please. I think CT images or those things like at least try to do some different topics. If you, as example, if you find type the colon cancer, colorectal cancer, you will get some 3 to 5 question, or I can't remember, just example. Then just open it and just try to find the image, and then take a screenshot, because this does not have everything. I'm just randomly take some screenshots only, because these images are very important in your exam. Okay, those are pure marks. So here, there's a what you can see in here, doctors. This is an example that I can show you. Here, there's a small sigmoid stricture here. Sigmoid stricture here. Obstructing sigmoid cancer is the common cause of large bowel obstruction in the patient, right? And here, what you can see, the dilated proximal colon, right? The proximal colon dilated, the bowel obstruction present. Why? Because of this sigmoid stricture, right? Maybe this can be the cause for the cause is the cancer, right? The colorectal cancer here, right, doctor? The sigmoid cancer. Okay, so this kind of image that you can get for the colon cancer, right? The sigmoid cancer here, and yeah, the other picture. Here also, what you can see in this image, what type of large bowel obstruction can you see in here? What is the highly dilated? Because I explain about, right, different types of obstruction, and why the cecum is dilated, right? I have explained what is the importance of the ileocecal valve, right? How the dilation happen, why the cecum is dilated. I have explained everything mechanism. Today I am only just explaining about the these CT findings only, okay? So here what you can see, the cecum is dilated, right? Here can you see the dilated cecum here? Dilated cecum. Why? What is the reason? Due to the sigmoid stricture, sigmoid cancer here, right? Because of that, there is a dilated cecum, right? Dilated cecum here you can see, right, doctors? Dilated cecum. Okay, so we'll go to the sigmoid volvulus. Sigmoid valve. What you can see in the sigmoid volvulus in the CT? Okay, first tell me about the X-ray image in what you can see. X-ray image in what you can see, doctors. Coffee bean sign, right? Sigmoid volvulus, the coffee bean sign, right? So in the CT, can you see the coffee bean signs? Yeah, still you can see the coffee beans appearance, right? The viral sign, the very important, the viral sign, the bird beak sign, and markedly dilated the sigmoid column, right? This is the most common volvulus usually. Okay, tell me the sigmoid volvulus. What are the key points that I told you that day to remember? Key points. Key points that I told you to remember that day. Do you remember the key points like which type of patient is having sigmoid volvulus? Which type of patients? Elderly, what else? Okay, all the patients constipated, like chronic constipation, right? Then where like which residential home patients, right? Residential home patients. Wait 1 minute, I'll open that file as well. Yeah, doctor, what to do, right? For my side, I did the session, right? So what I can do, I will try to do it again. It's also a very huge session, and okay, I told everyone to join, right, that day. Okay, if I have time, I will do it after the August exam week. Okay, after the August exam week. Otherwise, earlier, I don't think I can able to do it, but let's see. I'll show some. Okay, I open that one as well, just in case if you need anything. Yeah, doctor. Yeah, I can totally understand. The thing is, actually, that day I have the problem with this thing because, yeah, let's see if I can do it again, I will do, but not now. Okay, not now. At that point. Because in emergency question, they are very clearly mentioned who are the people that mainly. Here, in developed countries, this condition relatively unusual and typically occurs in elderly nursing home, residential, and presumed by related chronic constipation. Sigmoid volvulus seem the more frequent in certain developed countries where diet probably play a certain role in its etiology, right? Okay. Can you tell me the management for the sigmoid volvulus? Management. Management doctors? Tell me the management. Sigmoid, extra question. Quickly, quickly. Sigmoid volvulus, extra question. The management. Okay. Okay, what about the cecal volvulus? Cecal. Cecal volvulus, what is the management? Surgery, right? Very important because those things are very important. Here, yeah. Here, okay. A stable patient, you have to do the endoscopic decompression first, right? If the you have the unstable patient, then you have need the emergency surgery, right? Otherwise, you can start with the stable patient with endoscopic detorsion, right? If you do sigmoid colectomy later, according to the patient's other factors and all, right? Other comorbidities, the patient's surgically fit or not. Those things you can decide later. And the cecal valve is very important. The definitive management is urgent surgery. We are not waiting with the endoscopic decompression. Very important. Okay, don't mix these things up because those two have asked in July exam, and you should not miss those things. Okay. Okay. Here, sigmoid valves. Let's see. Here, the anterior posterior. Here, what you can see in here. Here, what you can see, doctors. Because some cases, doctors, just 1 minute. I'm getting a call. Hello. Okay, that was a unnecessary call. Okay, here. So sometimes in here I have attached because the most important points are the X-ray findings because sometimes I have attached those things as well. Yeah, I'm not going to explain, but here I want to explain this one. Here. Okay, imagine 72-year-old woman. LBO caused by sigmoid volutes. A CT scout image shows the dilated air-filled colon terminology is markedly dilated sigmoid colon folded upon itself with its apex, the coffee bean sign, in the midline upper abdomen. The black they have, yeah, here you can see. Can you see? Can you see, doctors? Because even CT you can see this one. Okay, CT you can see this coffee bean sign, right? Okay, here the other signs what you can see here. Let's see what are those things that they have shown. Here, CT of abdomen and pelvis is obtained revealed in the colonic volvulus in the left mid to upper abdomen, like blur arrows. Yes, a blur arrows. Sorry, blue arrows. Okay, here you can see the mid to upper abdomen. Okay, then involved in the distal transverse colon and descending colon with gaseous colonic distension 8.5 centimeter red arrows. Okay, here. Then a characteristic viral pattern, right? Viral pattern here. Viral pattern you can see in yellow arrow, right? So why it is viral pattern? Why? What is this viral pattern? Why you can see? Why you can see this viral pattern? So what is this viral pattern? That day I explained what is this viral pattern? What you can see? Tell me, Dr. Sao, you have shared. Mm-hmm. Yeah, you can see, but this twisting, right? So twisting, because like volulus mean the twisting, right? So you can see, but twisting of this mesenteric artery around the this area, right? So that's why we call the viral, right? Viral fold or viral sign, right, doctors? Okay, so this viral sign can be seen in both volvulus, right? So common feature for all the volvulus. So I will show you the cecal volvulus as well here. Okay, what you can see in the cecal volvulus, what is the typical picture? What is the typical picture? What is the typical picture, doctors? You can see which sign? Embryo sign, right? Some doctors are remembering it as a comma sign, right? Here, what you can see in here, what you can see, doctors, this arrow,
Site
this
of
arrow.
transition.
What about the doctors? Okay, here this super radiograph shows the gas distended segmented of bowels, the cecum, right? Here, this is the cecum within the mid abdomen. The base of the cecum is directed toward the upper quadrant and the ileocecal valve. Here, the ileocecal valve, right, is you can see in from this here, right? Because I have explained this one. Okay, so let's see the other image here. So this is a coronal CT, okay, coronal CT. Abdomen pelvis, 81-year-old woman with LBO caused by the cecal volvulus. Image show the displaced cecum in the mid-abdomen with its apex located in the left upper quadrant, right? Left upper quadrant, and the ileocecal valve is displaced toward the left upper quadrant as well, the arrowhead. Here you can see here the vial sign, right? Here the arrowhead and image after administration intravenous contrast demonstrate the vial sign in here, because I think this is a series of image, but I got only this image, okay? This image because I want to show you the vial sign, right? Vial sign, very important. Viral sign, because viral sign is a typical for the volvulus, right? Volvulus. And when you consider with the clinical presentation and the dilation of the cecum and everything, you can think about the management, right? You can think about the management because Okay, because as the many doctors have not attended that day, uh, okay, I'll do one question to understand like how the difference, how the sigmoid volvulus present and the other one. So 76-year-old woman present to the ED with 12-hour history of acute abdominal pain, distension and absolute constipation. He has no significant medical history and does not take any regular medications. On examination, appears uncomfortable. Pulse rate 100, blood pressure 130 by 85, respiratory rate is 18 and SpO2 97 and the temperature 37.8. Abdominal examination revealed distended abdomen with the area of localized tenderness in the left lower quadrant. A plain abdominal radiograph shows the characteristic change of sigmoid volvulus, right? You can see here. And so, which one of the following is would be most suspicious for infarction of the sigmoid volvulus? So, this is a good question. That day we have done, but the other doctors, please tell me, what do you think? Right? Mm-hmm, yeah. It's what? The localized tenderness in the lower quadrant, right? Otherwise, soft abdomen would suggest the underlying peritoneal irritation, which might be the secondary inflammation and ischemic changes of the sigmoid colon, right? So very, yeah, it's a very important. And I'll show. Okay, here. 72-year-old man present to the ED. Monday history of increase in central abdominal pain and abdominal distension. This accompanied by constipation for past 3 days. Medical history include the sigmoid colectomy for carcinoma 8 years previously, and on the examination he looks unwell with the blood pressure 95 by 72, pulse 104, the temperature 37.2. His abdomen is distended and tense with the area of localized tenderness and the guarding on the right side. X-ray is given, you can clearly say what is it. So what is most appropriate, the plan of the patient, the management, what you need to do, doctors, here? Quickly answer. What is the answer? Okay, the patient is having what? GERD in, and the localized tenderness also present, okay? And the patient is presenting with the embryo sign. So what you need to do here? So cecal valves in the plain film include the massive dilated loop of large bowel, here you can see, and the patient require rapid surgical intervention to reduce the risk of progressive intestinal ischemia. So laparotomy is the correct management option, right? Correct management option. Okay, so we'll go to other, yeah, we have a lot of file, right? Okay, now tell me, and here also you can see the viral sign and dilated bowels, right? Viral sign and dilated bowel. So just for the mainly, they are not asking for CT for the cecal and the sigmoid volvulus, okay? Because like both those things can be present, the viral sign is same, right? Otherwise, like the appearance, the embryo sign and the coffee bean sign, you have to differentiate even in CT, right? So there's no like many difference. Just remember the main point, the how the appearance and how viral sign those things present, because those viral sign is like common for both of them. Okay. So the next one, diverticulosis. So diverticulitis, how it present, the diverticulosis and the diverticulitis, those things. These are two different things, okay? How those things present, How those things present, doctors? So you can see the wall thickening, right? The inflammation, the diverticula, right? Some cases you can see the clearly the diverticula, pericolic fat stranding, and the sometimes the severe cases you can see the abscess as well, right? Because we all know we have uncomplicated diverticulitis and complicated diverticulitis, right? In one of clinical manifestation in the in the complicated one is the abscess, right? So like that. So I'll show pictures. This I don't think they will ask from this CD, but I have attached for sake of attaching it. Okay. Even like these are not very clear because I couldn't find the proper one in the internet. So here, 74-year-old man with 10-year history of obstipation presented with the abdominal pain showing a large amount of stool in the sigmoid colon. And the cluster of gas will diverticula in the descending colon, right? Here, you can see the stool, right? It's not very clear. The stool is like the air pockets in the gray color area, right? So you can see the like constipation, the impacted stool in the sigmoid, and here they are given here the gas will diverticula in the ascending colon, right? In this area they have mentioned the gas filled area only, like not clearly visible in the diverticula. Let's see, I think this is good. Let's see here. I have not seen they have asking from this one, but I have attached it here. This presented with the constipation and intermittent painful lower abdominal cramps showing the thickening of the sigmoid colon wall here, thickening. Can you see the thickening part is here, the diverticulus, right? Diverticulitis due to the here mycosis, a combination of hypertrophy of their circular muscle layer, shortening of tinea and lumen narrowing. Just think it as this is the case of diverticula. Okay, I got from that article. Here the inflammation and the thickening of wall you can see. Okay, can you see the thickening part here? And the narrowing of the lumen you can see because of the thickening. Okay, so yeah, those are the features. Just remember the wall thickening, the diverticula, not in all the cases, the pericolic fat stranding. Yeah, those things. Yeah, most commonly affect colon. This can be a better option because they are giving the presentation how this diverticule. I hope everyone know how it is present, right? In that case, once you see this one, the thickening of the wall, especially the sigmoid colon, you can think about the diverticulitis, right? Okay, how this gallstone eel is present? So how this gallstone eel is present? Gallstone eel is, doctors. So that day also I explained, right? Regular striate. So first of all, how this gallstone eel is present, how this gallstone eel is formed, how, doctors, how due to what? I hope you remember. I explained in the theory. Mm-hmm. So, what is the reason, right? Long-standing gallstone and the recurrent cholecystitis and those inflammation occurring again and again, right? Then there can be, because the gallbladder, what is the next organ? Usually, next you can see the duodenum, right? Duodenum, and because of this inflammation and everything, and there can be a fistula formation, right? Cholecysto enteric fistula, right? You can see in here. But mainly cholecystoduodenal fistula, right? Enteric mean the overall idea, but mainly this affect the cholecystoduodenal fistula, right? Then this goes on fast into this fistula in this intestine, mainly that can commonly impact in the terminal ileum, right? Terminal ileum. Because of that, we call it the gallstone here. That doesn't mean like they are like generated in there. That's because of the fistula and that travel to that area, right? Basically chronic inflammation, then fistula formation, right? This stone into the bowel and impact in the terminal ileum, right? And you can see the small bowel obstruction, pneumobilia, and ectopic gallstone here, right? So yeah, okay, here I will. Okay, this is the one. Here, can you see the gallstone in the terminal ileum, right? It's a stone, right? Stone. Okay, what is it? Okay. Sorry, I got the message. So, gallstone in terminal ileum, right? Here, air in the biliary tract. Can you see a small like air in black, right? Air in the biliary tract, then other than distended small bowel loop, right? Distended small bowel loop, small bowel obstruction. Here you can see this triad, right? This mic is on. Okay, thank you. Everyone is okay. So this is the triad that you can see, right? This is the triad that you can see. My doctors. So here also, this also a picture. Here, the stone. Here, a stone impact. Here also, yeah, like that. So remember the regular triad. I couldn't find the image in the e-medicine, I think. Because first I'm going with the e-medicine. It is not there. Then I jump into some other, the guidelines or research paper in the internet. Okay, remember this. Try it. Next one, intussusception. So how intussusception present? Intussusception mean what? We have the telescope, right? Telescoping. So what is invagination, right? Invagination is present. So in which organs you can see? What is intussusception? What is intussusception, doctors? What is happening in here? What is happening mean one segment of the bowel, right? Bowel go inside the other segment. Here can you see this part of bowel go inside this segment. We call it invagination, right? Invagination, and we call it telescope, right? Yes, telescope appearance, right, doctors? Okay, how you can see in this in CT? This can cause bowel obstruction, right? Ischemia. What you can see in here, doctors, in intussusception? In the CT find is very important. The target sign, right? Target sign, right? Even ultrasound, you can see the target sign, right? Doctor's target sign. Do you remember when we are doing the intussusception in the pediatric population? And pediatric cases, adults also can cause, right? But commonly in pediatric population, the most sensitive one is what? The ultrasound, right? Ultrasound in the RCs, they clearly mentioned. You can see the target sign or donut sign here. This is a donut sign here. And here, can you see the donut sign very clearly here? The donut sign. Okay. So keep in mind. Then acute appendicitis. How this present? Acute appendicitis, inflammation of the appendix, right? Appendix. So here. This is again mentioned in what? Mentioned in life in the fast lane. Okay, you can find it appendicitis, life in the fast lane. Then you can find the CT images. So normal appendix is usually 6 millimeter or less in diameter and associated with the clean dark appearance of surrounding fat. The image shown the next note here, you can see the appendix and the fat. Okay, appendix and the fat here, less than 6 millimeter. Acute appendicitis. The key imaging finding can help to confirm the diagnosis of acute appendicitis, what dilated fluid-filled appendix that is greater than 6 millimeter in width. Can you see? Here it's like very little light here, and can you see it's like dilated, right? Dilated, the fluid-filled appendix. The inflammation around the appendix, a strand in a wavy lines of and the haziness of the fat surrounding in the appendix. Here, periappendial inflammation, right? Periappendial inflammation. Can you see the fat is inflamed, right? Inflamed. That is the things that they are mentioning. And the bright calcified deposit in the appendix, appendicolith here. Appendicolith you can see like the something, the bright calcified, because you can see the calcification in the bright color, right? Then deposit you can see in here, right? We call appendicolith, which can obstruct the lumen and be the cause of appendicitis, right? Okay. Yeah, doctors, can we take a 5 minutes break? Just for 5 minutes break, okay? Because I'm getting an important call from my brother. Yeah, I need to pick up it. Okay, just take a 5 minutes. I'll come back. Hello. Hello, doctors. Yeah, okay, we can continue. Sorry for that. Do you understand, right? Because this is my first CT session. This is my first CT session, right? I also try so hard to understand you. That's what I'm asking. The thing is, you need to write, make your notes so you can like anything, okay? So we just mentioned, remember these are very important for the acute appendicitis. We have 3 points to remember, right? Because those things can be present, right? Okay, remember the appendicoly. It's a very important thing. Okay, so yeah. And here, perforated appendicitis, how it present? How it present, doctors? Perforated one. How it present? Okay, here. When appendix is perforated, many people expect to see the straightforward, well-defined perforation within air fluid outside the appendix. While that may be the case with some patients, there's a spectrum of different presentation we can see from early perforation to late perforation. Stage will greatly influence what you see. Okay, there are three essential imaging findings. So, thin enhanced wall of the appendix will become discontinuous at the site of perforation. A discontinuous. Okay, they are telling the enhancing wall of appendix will become discontinuous at the site of perforation. Because of that, there's a perforation, right? So discontinuation you can see. Then you will see a large amount of inflammation in the right lower quadrant affecting the nearby structures, which can be described as a localized peritonitis, right? You can see with the localized peritonitis, the inflammation and all, right? Inflammation and all. Then abscess formation will occur from the content that leak out from the ruptured appendix, and abscess will look like a fluid density collection with the wall that is variable thick and enhancing depending on the how organized a wall of thick collection is, right? Can you see like little wall here, and these accumulated things are here inside it with the wall, right? Okay, I'll show you because in the e-medicine we have two questions, right? We have two questions. This is the one, and where's the other one? Yeah, this is the other one. No, not the. This is not the other one. I have only attached one question because this question came in under phlegmon and the appendiceal abscess, right? Appendiceal abscess. Okay, so I hope you get the idea because I don't have like a better images than this because these are the only images that I can show you. Okay, so yeah, and what is appendiceal masses? So, ill-defined inflammatory mass in the right iliac fossa around the appendix. Thick inflamed appendix may not always be clearly visualized. Markedly periappendial fat stranded. Matted bowel loops or omen tube surrounding the appendix. The bowel wall thickening of the adjacent cecum or terminal ileum. A small amount of free fluid may be present. No well fluid collection because this is appendiceal mass, right? In e-medicine, if you are comfortable with, if you are like familiar with those questions, you can say, right? There's a, I think this is the one question. This is the one question they are mentioning here. They are mentioning here phlegmon, right? Phlegmon, that being inflammatory mass. And again, the question they are mentioning, it seems like because of its diameter and everything, it seems like a abscess something. Okay, that was kind of weird question. Anyway, like you need to understand the management in this case, very important. Okay, if you have not done it earlier, please go and do. There's a two question. Please those do those two questions, right? So here, appendiceal abscess should be treated with the antibiotics and percutaneous drainage, depending on the size. That is for the abscess, okay? Immediate surgical treatment. And here, you can see. Can you see the mass here? Can you see the large mass in here? They have mentioned in the question 8 centimeter. Okay, I think better I can show you that one, right? Otherwise, you are not remembering because this question came on different months. Okay, here. Previous was 16-year boy with 10-year history of increase in pain in his lower abdomen and the right side. The pain is constant, and the nature, and it's now bad, and he can't go to school. His blood pressure 115 and 70, pulse 98. Okay, pulse 98. Whereas the pulse 98, temperature 37.8, abdominal examination, there are mass palpable in the right iliac fossa with tendon palpation. The rest of physical examination is unremarkable. CT scan is performed here. Here, can you see the, like, this seems like 8 centimeter, right? This is the 10 centimeter one. It seems like 8 centimeter around, right? So which one of the following is most appropriate plan of management? Now tell me, doctors, what do you think? What do you think? What do you think, doctors? This is very important. Okay, you all going with B, right? I quickly mark that one and go. Let's see. Yeah. Okay, finding of palpable tender mass in the right iliac fossa has been present for more than 3 days, characteristic of appendix mass. Here they have mentioned appendix mass. Okay, this is the result of perforation of appendix which has become sealed off. The consequences of such perforation can be vary from uncomplicated inflammatory mass to abscess formation. In this case, the clinical diagnosis has been confirmed by CT scan result. CT shows the clear defined 8 centimeter heterogeneous mass in the right iliac fossa. This is appendix abscess. Okay, this is an appendix abscess, and appendiceal abscess is found about 4% of patient diagnosed with appendicitis. Although this is relatively uncommon, this is important to be aware the impaction of the find in appendiceal abscess and how it affects patients' management. Very important. This part, make a note. Okay, and this part both. You will have to make a note, right? Current recommendation management for appendix abscess is non-surgical approach. For an appendiceal abscess more than 5 centimeter, percutaneous drainage is the most appropriate initial plan of the management. It is most important treatment plan for the patient described in this clinical scenario. It's around like 8 here, the 8 centimeter here. You can see they have given the mark here, the 10 centimeter, and here the 8 centimeter. Seems like 8 centimeter. Doctors, just read this, okay? Just give me 1 minute. Hello? Okay, sorry for that. Okay, so we were here, right? If the scenario not responsive to the percutaneous drainage, then laparoscopic or open appendectomy with washout drainage should be performed. Provided that the abscess responds to the antibiotic and radiological guidance drainage, then elective appendectomy could be considered, but this must be wait until this has been resolution of the inflammatory and infective process, right? For case of phlegm, uncomplicated inflammatory mass with no abscess or abscess less than 5 centimeter, the less than 5 centimeter or the phlegm uncomplicated inflammatory mass, recommend patient with the treated with antibiotic and conservative management, right? So what you need to understand from this, you have to make a note. Abscess less than 5 centimeter, or if there's uncomplicated phlegm, you can go with antibiotic plus conservative. If it is more than 5 centimeter abscess, then you have to go with drainage plus antibiotic, right? Later you have to do the definitive surgery, right? I hope you get the idea. It's a very important thing, right? So this is appendiceal mass, and they have take it as the abscess. Okay, this is a complicated mass. Maybe they are telling it can be abscess, right? Okay, yeah. So the next thing. Okay, so the phlegmon and the mucocele, other thing you need to understand. Okay, there was another question about this mucocele as well. Okay, so what is the difference between this phlegmon and mucocele, appendiceal mucocele? So appendiceal phlegmon is an inflammatory mass due to perforated appendicitis. Near the mucocele is mucus-filled dilated appendix due to the luminal obstruction. Here the thick, inflammate, often poorly defined. Here the mark dilated more than 1.5 centimeter. Thin wall cyst, right? You can see. And here wall is here thick, irregular. Can you see the thick, irregular wall you can see in here? Here, thin, smooth, you can see may be calcified, right? The content here inflamed, soft tissue and edema. Here, homogeneous, low density mucin. And this appendiceal mucocele has the high risk of cancer. Okay, so that is another important point that you need to understand. Okay, if it is here the fluid collection, only phlegmon, there's a no fluid, but if it is can be converted to the abscess, in that case, there can be a fluid collection, right? Here, fat strand marked periappendiceal fat strand in here may be minimal or absent, okay? Then wall classification, see absent, here may be present like that here. And this is the picture you can see here. Can you see it's like a here mucocele of the appendix, right? Mucocele of the appendix, cystic area of the appendix here. Present as a cystic mass in the right iliac for sound CT imaging, often with the calcification in the wall, right? Calcification in the wall. Mucocele of the appendix have malignant potential and can lead to the pseudomyxema peritoneal if ruptured, right? Hemicolectomy is the preferred treatment for mucocele for the appendix to minimize the risk of rupture and peritoneal sediment, right? So very important, keep these points in your mind, okay? Here, the mucocele is the appendix are uncommon but important recognized due to the malignance potential. This neoplasm can metastasis and spread locally, potentially leading to the pseudomyxoma peritoneum, right? This is very important. This extra thing, but I wanted to add because it's important. They cannot. Because each month the AMC is asking like a lot of news questions, right? Maybe this can ask. Okay. So, next case, the acute pancreatitis. Acute pancreatitis. So, what is acute pancreatitis? Tell me, doctors, acute pancreatitis. What do you know about it? What happened to the small worm? The small worm. Tell me, doctors. A small wall is being swollen, right? Yeah, get bigger, right? Okay, wait. What is here? How mucocele, right? Mucocele usually symptomatic, but if it is like symptomatic, you can see the right lower quadrant pain, right? There can be a palpable mass in the right lower quadrant, right? It can be also if it is like mainly if it is ruptured, there can be nausea, vomiting. Yeah, like mainly it's asymptomatic, but if it is big and ruptured or like complicated cases, you can see those features because it's mainly associated with the malignancy. Okay, malignancy is here. What you can see, the worm is getting bigger, right? Here, can you see the small worm is getting edematous and inflamed pancreatic gland, and around this you can see this fat strand in, right? So that means the inflammation of the pancreas, right? Peripancreatic fat strand in fluid collection, pancreatic necrosis in severe cases you can see. But usually we are not doing the acute pancreatitis. We are not doing the initially this CT. Okay, we are doing most of the time if there is a complication, so chronic pancreatitis present, right? Otherwise, we have the diagnostic criteria, and from the diagnostic criteria, we can diagnose it clearly, right? So, how pseudocyst is present? How pseudocyst and what is pseudocyst? It's a well-defined fluid collection adjacent to the pancreas, right? Develop usually equal or more than 4 weeks after acute pancreatitis. No solid component or daughter cyst. Wall is mature and fibrous, right? It's like a encapsulated fluid after pancreatitis. Fluid area. Can you see here? This is a pseudocyst. It's like a football, right? It's like a football here. This is from me. This is the picture given. The most pancreatic pseudocysts are acute pancreatitis resolved spontaneously over 6 to 8 weeks. If asymptomatic and without complications, interventions for pancreatic pseudocyst is reserved for persistent symptoms, infections, bleeding, obstruction, or failure to resolve after appropriate interval. Because these are like usually self-resolving, right? If it is not complicated, but if it is not self-resolving, you have to think about the management, right? Endoscopic internal drainage is preferred when interventions is needed, and then collection is mature, adherent to the stomach or duodenum, and symptomatic, right? So this is the way I'll show another picture, CT pseudocyst. Because in pseudocyst, they are usually given CT, okay? They are usually given. I can remember it's like a football. Here's a giant football. Here, you can see like a giant football, okay? Giant football kind of thing. Okay. Okay, acute cholecystitis, what you can see. Usually in the cholecystitis, we are usually using ultrasound. Okay, ultrasound are the main thing that they are giving. Okay? Ultrasound are the main things that they are giving. But here, like, don't like add, but give it an idea, give it a rate. Maybe they can ask from here. Okay, otherwise, the best one is acute cholecystitis, but you can see the gallbladder thickening, right? Those pericolic, the fluid accumulation, right? Those things can see, especially in the ultrasound. You don't need to go with the CT. What gastric outlet? That is not necessary here, right, doctor? So that's a separate thing. So you're asking gastric outlet from pseudocyst. Oh, what is? I don't get it. So we'll discuss this one first, right? Imaging part, doctor, because a lot of things I have to explain. And yeah, after session, if I have time, I will explain. So for now, we'll focus this one, okay? So here, CT finding, you can see here the thick gallbladder wall, right? Then gallstone, pericholecystic fluid, the same thing. You can see the distended gallbladder here. Here, this is the CT scan of acute cholecystitis. And so here, gallstone you can see, and the gallbladder wall thickening also you can see here. Gallbladder wall thickening, and the cystic duct obstruction also here you can see. Cystic duct obstruction, okay, not the common bile duct. Okay. So yeah, here remember the ultrasound is the first line. Okay, don't confuse. But keep in mind because you all know where is the gallbladder. If is the gallbladder wall is inflamed, you can see it like this. Okay. So yeah, and here this is another one. Here the axial CT image, acute gangrenous cholecystitis here, and you can see the wall as well here. Where's the enhancing gallbladder wall, the black one? Okay, black arrow. Can you see the here enhancing gallbladder? Because this is a gangrenous cholecystitis, and the striated appearance of the medial wall, the white arrow, and poorly enhancing wall, black arrow, and calculus white arrow impacted in the neck of gallbladder. Yes, here you can see the wall and the impacted. Sorry, these gallstone you can see like this. These are some examples. I got it from the internet. Okay, so the same thing. Okay, okay, I have attached the gallstone areas in the wrong place. Okay, it's fine. So next one, what do you know about porcelain gallbladder? Porcelain gallbladder, doctors. What do you know? Porcelain gallbladder. It's a calcification of the gallbladder due to the chronic cholecystitis, right? Usually associated with the long-standing gallstones, right? CT findings, you can see the bright, curvulent, or complete calcification of the gallbladder wall, because this is a easy thing, right? Easy things, and it's very easily understand in the here in the gallbladder. Can you see the gallbladder, the porcelain gallbladder, the calcified rim, right? Calcified rim. This has asked in the earlier, doctor. Are they really need? What are they? CD you need. You like. if you get CT, you have to answer, right? Otherwise, yeah, you don't need. But we don't know, right, what you are getting, because recently they have given a lot of questions from CT. Okay, so ascending, because these are all the diseases are AMC's high yield topic, right? Maybe better you should get the idea, right? You should get the idea about these things as well. The CT, like little bit idea, because you don't need to be like a pro or anything, because you are not going to do the radiologist exam, right? Because, but get the idea, because most doctors have asked me. That's what I'm doing. I'm doing this one. Okay, so we'll move to the next one, ascending cholangitis. So ascending cholangitis, patient having the biliary compression, right? Compression due to this dilated bile, dilated stone, sorry, due to this obstructed stone in the biliary tree, right? In the, especially the biliary duct, right? So what you can see, doctors, what you can see in this, what you can see here, can is the dilated here, dilated CBT here in this. You can see the dilated CBT, and with the small amount of adjacent fluid suggesting ascending cholangitis here. The fluid accumulation also can be seen, and other than very clearly see the dilated CBD, right? Dilated CBD. Okay, like that. Then I don't think they're asking about from ascending cholangitis CT, but I have attached it. So this part they are asking acute mesenteric ischemia. This is very important because emergency also they have given about it. Okay, the CT images. Make sure you know the CT images given in the e-medicine, you have already covered. Okay, that is the only thing I can tell you. So how acute mesenteric ischemia present? Tell me, doctors. So ischemia means like reduced blood supply, right? Reduced blood supply. So CT find what are the things you can see. First, we'll do some questions. Okay, we'll do some questions here. 67-year-old woman present to the ED with 12-hour history of increase in abdominal pain. The pain is constant and spread all over her abdomen. She has a medical history of type 2 diabetes, hypertension, regular medications, and metformin and perintropil. On examination, she appears unwell. Pulse rate is 120. BP 110 by 70 and respiratory rate is 22, temperature 37.4, abdomen diffusely tender, CT is given. So why you are telling it as a mesenteric ischemia? What are the CT findings you can see? What are the CT findings you can see here? Tell me, doctors. Tell me quickly. We have to. Yes, here. CT scan shows the gas in the portal vein. Image one here. Here, can you see gas in the portal vein, right? So, what are the other things? Other things. And the area of pneumatosis intestinalis in the mid small bowel. So, do you remember I told you it's easy, right? It's easy, right? Can you see these, the bowels like dotted kind of thing, right? Dotted kind of thing. We call it what? Pneumatosis intestinalis. Can you see here? Can you see the wall has the air pockets, right? Air pockets. Can you see? Those things are very important, right? PI. PI mean what? That is pneumatosis intestinalis, right? Very important, means small bowel. So these two are the things that you can see in here. Taken together with the clinical picture of diffuse abdominal pain and tachycardia, the radiology will find highly suggestive of mesenteric ischemia with probable bowel infarction, right? Hepatic portal venous gas can have several different origins, but mesenteric ischemia is the most common and concerning cause, right? Mesenteric ischemia occurs when There's inadequate blood flow to the intestine and leading to the tissue damage and potential necrosis. It can be caused by arterial occlusion, venous thrombosis, or non-occlusive present. Patient is risk factors, diabetes, hypertension, increased susceptibility to this condition. Stomach is distended and uh, likely due to the decreased persistence of the ischemic bowel, right? Okay, so here, what are the features that you can see? I think there are 3 to 5 questions in the e-medicine. Do it, okay? Poor bowel wall enhancement, bowel wall thickening, pneumatosis intestinalis, portal venous gas. These are the things that you can see. And here the CT is the investigation of choice. Yeah. Yeah, okay. So the bowel perforation, how this bowel perforation present, doctors, very important because these are asking. I can tell you this is the asking one of asking part. So where you can see the bowel perforation. If it is there's a peptic ulcer, ischemia, obstruction, appendicitis, diverticulitis, trauma, those cases, there can be a bowel perforation, right? So key finding is free interperitoneal air in the air and the peritonitis. Can you see free intraperitoneal air? Free intraperitoneal air is the first finding in that should raise the suspicion of perforation when there is a large amount of air that can be hard to miss even on the soft tissue window. Below you can see the black pocket here. Black pocket. Can you see the air? Right? Air. So intraperitoneal air accumulation, right? While seeing the large amount of air confirm the perforation, you still have to determine the cause. Shift into the bone or lung window. That is the type of the windows that we are using in the CT that we can use to evaluate the pattern and the cause, right? So this is a bone window and this is a lung window. Anything you can see here, right? The air in the peritoneal fluid, right? Here also, here, air in the peritoneum. Right, doctors? So how peritonitis present? Peritonitis is the other helpful clue to make the diagnosis, particularly for the small localized perforation that does not distribute air all over the abdominal cavity. This pattern occurs more commonly in the perforated diverticulitis appendicitis. Right? Thickening and increase the enhancement. Can you see? Thickening and increase the enhancement, right? Like that. So the toxic megacolon usually we can find it in X-ray, right? Typically X-ray, the highly dilated colon you can see, right? Toxic megacolon. Other than in here also you can see the dilation, right? You can see the bowel dilation, by like very severely bowel can be dilation, right? Here can you see the like that. So you can see the dilated transverse colon, loss of colonic hostra, segmented parietal thinning, and the intraluminal soft tissue mass. You can see these are the things that here you can see the toxic megacolon, right? So you can see the like loss of hostra, right? The large dilated bowel, transverse colon, right? Here this is a typical X-ray presentation. So Gillies syndrome. Gillies syndromes are one of functional bowel obstruction, right? Functional bowel obstruction. And in that case, what you can see, so Gillies syndrome is, you all know, right? When that day we discuss what are the causes of, right? So usually can see in elderly patient, bedridden patient with comorbidities. It can be autonomic, multifunctional autonomic control, massive dilation of colon. You can see absence of mechanical obstruction. So no transition point, right? You can see like that. So what you can see, diffuse colonic dilatation, no transition point, no obstructing lesion, especially in those elderly bedridden patients, right? So here you can see the large bowel obstruction without any mechanical obstruction, any lesion. Here the presence of dilation of the large bowel without evidence of the transition point or mechanical obstructing lesion. This chronic dilation may be extended to the rectum, right? Like hugely dilated, right? So paralytic ileus, this is the usually the Ogier syndrome is associated with the large bowel only, but paralytic ileus that can be associated with the small bowel or large bowel, right? So yeah, here what you can see here also the no transition. You can see the gas in the rectum, but not in all the cases. Okay, can be see gas in the rectum, diffuse dilatation of the small bowel and the large bowel, right? Here you can see the large bowel and here the small bowel as well. Okay, those are not very important for the CT images, but like that's important X-rays. Okay, so another thing is when we discuss about the pathology, the renal, the pelvic pathology, renal stones. You can very brightly see the renal stones, right? CT find you can see the hyperdense stones, hydronephrosis or hydroureata associated. These are the features. Okay, here obstructing stone, like very bright color. You can see this stone, right? Here, this patient associated the infection tape behind the stone, right? I hope you remember there are some questions in obstructing lesion with sepsis, right? Because of this obstruction, there can be fever and hydronephrosis associated with. Like, do you remember the initial management that we are going with stenting? I hope you remember the stent applying question. That is a typical presentation of this, right? Where you should, yeah, like that. So here you can see the kidney obstructing stone, like very bright color, like that. And here also the large stone here is in the middle of the kidney, right? Middle of the kidney, you can see it's a very like easily you can see the stones part. And the pyelonephritis, pyelonephritis, you can see the renal enlargement, perinephritic fat strand. Anyway, like if there is a organ is inflammation present, itis present, you can see the these peri-organ fat stranding. Okay, those things I have not couldn't find the picture because that is not very important for the CT. So this is important. Abdominal aortic aneurysm. Important. Very important, right? Very important, this one, because they are giving CT for this topic. Okay. Here, we'll do this question. 65-year-old man present to the GP clinic with history of sharp right upper quadrant pain that begins suddenly in the morning, lasted about 20 minutes and then subside. He has no significant medical history and take no regular medications. He works as a accountant and has no relevant travel history. On examination appears well. Pulse rate is 90, BP 140 by 100, respiratory rate 60, SpO2 98, and the temperature 36.8. Abdominal examination is unremarkable with no tenderness or palpable mass. CT scan of the abdomen arranged and representative slice is shown. Which one of the following is most appropriate management? Quickly type your answer in the chat, then I can explain easily. Tell me, doctors. Okay, here. This CT scan shows the large abdominal aortic aneurysm. So show me where's the abdominal aneurysm, in which area. Okay, I'll give. Where's the aneurysm? Okay. Here appears the greater than 5.5 diameter. This is important incidental finding that require urgent attention, even though it is likely unrelated to the patient's presenting symptoms, right? This is incidentally found in one. Okay, here, can you see? Here also. So here this patient has clinically discovered 6.2 abdominal aortic aneurysm on CT imaging performed for trauma assessment. Here also abdominal aortic aneurysm. Okay, here they have given abdominal aortic aneurysm, rim of calcification in the vessel. His age and sex put him risk of aneurysm formation. Here with the calcification you can see right here. With the calcification you can see. Okay, so this is very important. The dilated aorta, mural thrombosis, retroperitoneal hematoma if ruptured, right? So here, and there's something important. Okay, here this is from Life in the Fast Lane. The diagnosis of AA is made when the maximum diameter of the abdominal aorta greater than 3 centimeter. However, aneurysm smaller than 5 centimeters do not pose a significant risk of rupture. Rupture becomes greater concern aneurysm that larger than 5 centimeters. Here can you see the usual aorta and here the aneurysm, right? Okay. Here when the aneurysm rupture, it can be relatively subtle because after rupture also sometimes they can give the CT, resulting in blood slowly leaking from the aneurysm sac, or it can be dramatic, resulting in the large amount of blood surrounding the aorta. I'll show a picture. Okay, here the aorta, then rupture, here the rupture present and here the blood. Okay, I'll show a better one here. The aorta, aortic wall calcification, and the wall thrombosis, the retroperitoneal free fluid, and the hematoma, the blood leaking. Okay, like that. So yeah, here the rupture blood. So those are the very important thing. Otherwise, you need to understand. Okay, so yeah, next question, next thing. Aortic dissection. How aortic dissection present? How aortic dissection? So aortic dissection mean there's a tear in the aortic intima that creating a true and false lumens, right? So what you can see, I'm not going to explain. And here the remember we have two types of right, type A and type B according to Stanford classification, right? The Stanford classification. Okay, here. Okay, what you can see. What you can see in here. Here, this picture stands for type B aortic dissection. So type B mean what? It stand for type B mean what, doctor? How to differentiate? Tell me. Aortic dissection. Tell me. What is stand for classification A and B? Where is the involving? Stanford A mean ascending aorta, right? Ascending aorta. If it is A, it's involving, right? I always told you to go with it's the emergency, right? If it is Stanford B, right? B, that is what? No ascending aorta, right? There's a no ascending aorta. So in that case, like you can start with the medical management, right? No, of emergency surgery, right? Okay, this is a Stanford type B, B1, okay? B aortic dissection or chest CT. Red arrows point the true aortic lumen and yellow arrow point the false aortic lumen at the level. Okay, red one is what? Red point the true aortic lumen, the red one, and the yellow one point the false aortic lumen, right? Everyone is having the idea, right? It's an intimal tear or ulcer presentation leading to the bleeding into the medial layer of the aortic wall, right? Creating a true and false lumen, right? True and false lumen. Intimate lines has true lumen. The false lumen is blood-filled channel within the medial layer. Medial layer. Then the progress may progress to the aortic rupture, re-entry into the true lumen via the secondary intimal tear, right? Like the main complications, cardiac tamponade due to regurgitation, and the type A due to the MI or stroke, type B acute kidney injury, those things. Okay. The Stanford involved the ascending aorta. 60% twice as common as type B. Type B limited to the descending aorta, right? Yeah, like that. Okay. Because I think this is the only picture I couldn't find. I could find. Yes, I could find this is the only picture. Here they are given the true aortic true lumen and the yellow is the false aortic lumen. And according to the here mid descending aorta, then in aortic root, see in celiac axis because they have axes like in different area we can see. In that case, just remember the two flaps, right? Two flaps here. The intimal flap, the double lumen you can see because of this false lumen, and the aortic dilatation you can see, okay? Because I have not seen they have asking from that, but you know. Okay, I have explained this one like hypotenuse, those things, how it present earlier in the session. Okay, then other things, because now I'm going to explain the cyst, hepatic abscess, and the those hyalid cyst like things. These are very important differentiate, okay? Is it boring, doctors? Is it boring? Are you sleeping? Tell me. Okay. What about other doctors? Okay. Interesting. That is good. Okay, okay. Okay, because I feel like everyone is getting bored. CT is none of my interest topic as well, right? Because yeah, I don't know. I'm whether explaining better or not. That's what I'm asking because I'm is focusing on key points. Okay. Yeah. If it is a simple hepatic cyst, how it present, I told you, like wall is thin and smooth. Take a screenshot if you want. Okay, then you can compare. I'm sorry, simple thing. Cyst, thin and smooth wall, right? A smooth wall. And contrast enhancement, usually no. Then homogeneous fluid you can see surrounding liver is okay. No septations, right? No calcifications. It's like a very benign, right? Very benign. It's a water density cyst you can see. So here the pyogenic liver abscess, very important, these three. Pyogenic liver abscess, amoebic liver abscess and hereditary cyst. You have to differentiate those from the presentation as well as the CT findings, very important. So how pyogenic liver abscess present? So wall are thick, irregular, right? Rim enhancement present, right? Usually abscess has the rim enhancement, right? The content is pus, there can be debris, there can be a with or without gas, right? Because this is a pyogenic, right? Then surrounding liver fat strand in an edema can be seen. Septions can present, right? Can present or not. Calcification is rare. Maybe the gas within the lesion may be present. Typical appearance, thick wall rim, enhancing abscess, right? Double target rim enhancement, double target sign or rim enhancement, you can see. That may be clear abscess, very important, you can see. But thick, a smooth wall, right? Thick, smooth wall. And the contrast enhancement is a rim enhancement, you can see, right? It's a homogeneous, low density fluid you can see. The surrounding liver mild edema can be seen. The interceptual usually absent. It's like a very good abscess you can see, like the round, right? Calcification rare. And here the solitary right lobe rim enhancing abscess, the most common, the right lobe one. And solitary hypodense lesion you can see. The hereditary cyst. It has thick wall, or well defined, may calcify, right? It depends on the different types of hereditary disease, right? The contrast here, mild wall enhancement only. Here you can be present it as a daughter cyst. It can be present with the septas. It can be has a detached membrane. So in case if it is ruptures, you can see the water lily sign, right? Surrounding liver usually normal. Septations present daughter cyst, right? We call because of this due to septation, there can be daughter inside the mom, right? Calcification common, right? If it's a chronic lesion, very common calcification. And the gas within the lesion, no. Then multiloculated cyst within a cyst. Notice is water lily sign, calcified wall. Those are the features, right? Okay. Okay, we'll go one by one. This is a pyogenic cyst. Okay, pyogenic cyst, how it is. Can you see? Pyogenic cyst, right? Pyogenic liver abscess, peripheral enhancing and central hypoattenuated lesion, solido gas in the lesion, right? Solido gas in the lesion, and segmental wedge shape or circumstantial perfusion abnormalities. On contrast, CT, the double target sign of characteristic image feature, liver abscess present. The double target sign, central low attenuate lesion, the fluid fill surrounded with the high attenuate inner rim and low attenuate outer rim, right? Like here. Here's a cluster sign. Okay, what is cluster sign? Features of pyogenic liver abscess, aggranation, multiple low attenuation liver lesion, localized area from solitary large abscess cavity. Here, they are like separated kind of thing, like a cluster you can see here. It's like a separated here also like cluster, but separately you can see the pyogenic liver abscess. This is the typical presentation. Okay, I'll show. God, what happened to my PDF? It's very ugly now. Because this should supposed to come here. I don't know what happened. Okay, so CT finding. So here I told you like it's a very good, right? You can very clearly see it's like a solitary abscess, right? Shape of abscess mostly round in shape, very in size, 4 centimeter, 12 centimeter. Well-defined lesion with attenuation value indicate the presence of complex fluid, wall enhancement, peripheral zone of edema with wall thickness around 3 to 15. the central abscess cavity with septation of fluid or debris level, but mostly not present. The no fluid can be present, and gas in the abscess associated. This is like a general idea. This is from the Wikipedia. Okay, Wikipedia. Okay, so here I'll show the here. 42-year-old man presented with a 2-week history of upper abdominal pain and fever. The pain is occasionally radiated to shoulder. Then recently returned from a 1-month trip to Thailand, the during which he experienced about the bloody diarrhea, but made full recovery. However, upon returning to Australia, he began to feel increasing lethargic and patient normal in the good health does not have any pre-exciting condition. On examination, blood pressure 118 by 72 and pulse 90, temperature 38.5. Abdomen is soft apart from the tenderness in the right upper corner. Blood tests reveal the leukocytosis and elevated ALP, while bilirubin remain within the normal range. The CT scan performed on here. So they are asking which one of the causative organism. So what do you think? What do you think in here, doctors? Here. Here, the patient is suffering from amoebic liver abscess. This is a kind of like not the very typical presentation, but here you can see, right, from the presentation and the past history and the clinical symptoms, you can still think about amoeba histolytica, which is the most common extraintestinal manifestation of amoeba histolytica infection. This protozoa parasite transmitted through the fecal oral routine from India, Africa, South Asia, South America. Travel history Thailand is having a prior to episode of dysentery. Raise the possibility of amoebic liver. CT scan shows the multiple intrahepatic lesions that are well defined hyperdense masses with the peripheral enhancing rim. Rim can see, right? Peripheral enhancing rim hyperdense. And yeah, the majority of amoebic liver abscess are solitary lesions. However, the presence of multiple abscess, such as in this case, is well recognized. Diagnosis made during the serology test of antibodies to entamoeba histolytica along with the imaging find. Aspiration of abscess is not necessary for the establishing diagnosis. But if aspirated, they contain cellular debris form the brown thick fluid called as anchovy paste, right? Sorry, anchovy paste. And here, why not pyogenic liver abscess limited to the amoebic liver abscess and the distinguish between these two disease based on the clinical cause and imaging finding can be very challenging with the regarding of pyogenic abscess formation. Okay, here the next question. Okay, what do you think? What is this? What do you think about in here? 42-year-old man to the ED with 1 week history of feeling generally unwell, fever and sweat. 2 days ago, pain in upper abdomen. He has significant medical history except for the episode of diarrhea 1 month ago. When he was on holiday in Bali, he takes no regular medications, drinks 2 glasses of wine a day, and does not smoke. On examination, pulse rate 100, BP 110 by 70. Temperature 37.8, physical examination, tenderness in the right upper quadrant, CT performed. Which one of the most appropriate management? And what are the doctors? Quickly answer. Okay, here, what can be concluded from the clinical present picture of the CT, single peripheral enhancing lesion that patient has a liver abscess. The etiology of liver abscess can be either pyogenic or amoebic or fungal. It's typically pyogenic and fungal abscess have multiple abscess and amoebic abscess tend to present with a single sub-abscess only. Overall, most liver abscess have pyogenic origin and this the biliary tract will be prime source of infection. The patient would screen with the suspicious serology stool testing to assess the diagnosis. Okay, what is in the chart? Okay, so here, entamoeba histolytica found globally and transmitted by fecal contact. Most infections remain symptom-free, but can be present in 8 to 20 weeks later after traveling to endemic area. The amoebic abscess would be treated first with metronidazole and close surveillance after confirming of amoebiasis cellular stool testing, right? Yeah, you are correct. So what do you know about hereditary cyst? Hereditary cyst. So what are the CT findings you can see? Here what you can see? Here what you can see? Which sign you can see? Here. Here you can see what? Here. Mom is here. Inside her there are daughters, right? Daughters are here. Mom, here's the mom. And inside her belly there are daughters, right? There are daughters. So you can see the daughter cyst here. Daughter cyst here, we call it septation, right? Septation. And here you can see the calcified rim, right? Calcified rim here. Calcified hydrid rim. So here also you can see the daughter cyst, right? Daughter cyst. Daughter cyst. Then here you can see the calcified rim, right? Calcified rim. And here also daughter cyst. And here you can see the water lily sign, the ruptured sign, right? Ruptured sign, the water lily sign. Okay, so I am not going to read the image question because you can give it a read later, right? And next I want to explain, okay, here also hereditary cyst, like a large hereditary cyst, right? Can you see it's a very large hereditary cyst with the classification, right? Okay, liver metastasis, because this question they have asked in earlier months. Liver metastasis, how it present? So there can be multiple hypodense lesion or there can be single lesion as well, okay? And there can be variable contrast enhancement you can see. Here what you can see. Here liver metastases are the most common malignant lesions of the liver and are typically hyperattenuating. So liver metastasis commonly show the peripheral limb enhancement due to the viable tumor at the margins with the central necrosis and lack of central fill-in with variable washout relative to the background liver. Hepatocellular carcinoma typically demonstrate the non-rim arterial phase hyper enhancement with subsequent portal venous delayed phase washout and with the associated capsule in large lesion. Hemangioma classically, so this is given like for all the cases, okay? The hemangioma classically demonstrate the peripheral nodular discontinuation enhancement in arterial phase with progressive central fill-in and persistent delay phase. That is for the other options, okay? But here it's like a liver metastasis. I will show better options here. Okay, here this is the question. Here, 66 came to GP, 5-week history of right upper quadrant and pain and lethargy. No significant medical history, no regular medications, 45 years smoke in history, and 2 standard alcohol drinks per day. On physical examination, pulse 80, 132 by 90, temperature 37.2. Abdominal examination, some tenderness in the right upper quadrant was found, but the rest of the examination are remarkable. CT abdomen shown here. Here, can you see different color, right? Different color. What you can see here, the metastatic liver disease. Here, the CT findings show the multiple lesion varying in size and the consistent with the metastasis disease. Here also you can see. Okay, here's the question that I got that part. Here's the question here. And here also metastatic one deposit of the metastatic. Yeah, here, okay, like that. Here also metastasis deposit you can see, right? So the thing is splenic injury. Splenic injury. What you should know about the splenic injury, very important. Because a splenic injury, do this question in medicine. Okay, do this question because according to this, you have to decide the treatment, right? So usually, in the patients with different grades of splenic injury, right? Splenic injury. So how? This is the one. So if the splenic injury present with the subscapular hematoma less than 10% of surface area and capsular tear less than 1 centimeter depth, then no operative management need. Okay, then image one. Image one is this. Okay, image one is this. Subscapular hematoma 10 to 15% surface area. Intraparenchymal hematoma less than 5 centimeter and laceration 1 to 3 centimeter in the depth, right? Like in here, this picture. In that case, also no operative management. If the image number 2, this one, subscapular hematoma more than 50%. Can you see like it's like around more than 50% surface area and intraparenchymal hematoma more than 5 centimeter and the laceration more than 3 centimeter depth. Non-operative management or embolization if stable. So number 4, this one. It's not very good, right? Okay, laceration involves a segment or hilar vessel with major devascularization. In that case, embolization of stable. If the shattered spleen, this is the one they are usually asking, shattered spleen. Can you see like the parts are not even invisible here? The spleen is injured and like the particles also not found, right? Shattered, right? Very damaged. In that case, you need to go with the surgery, right? I'm not going to explain this is too much because too much for this question because we have done these questions like in earlier sessions, right? The splenic injury, because you have to remember this by heart. Type splenic injury, then you can find these things and understand. Okay, they are usually asking given the presentation. And then they are asking the management. I have attached like sake of attaching. The other one is splenic abscess. How the splenic abscess present? Here, we'll do this question. 15, because this is also given in e-medicine. 59-year-old man present with a 1 week history of fever, chills, and left-sided abdominal pain. Medical history include hypertension, ischemic heart disease, take pain refill, and 4 weeks ago had a pacemaker inserted for heart block. 30-pack years smoke in history and examination. His blood pressure 110 by 70. Pulse 90, temperature 38.4. His abdomen is soft and apart from the tenderness. That's the left upper corner CT here. Okay, so it is a splenic abscess. Can you see the spleen is here and the abscess like it's very large abscess, right? Can you see here? Right here. The CT scan shows the well-defined splenic, spherical mass within the spleen. It's a homogeneous thin wall measuring some 8 to 12 centimeter from appearance is the clinical history and most likely to be splenic abscess, right? So, okay, this is the other important thing. So that's why I told you to remember the psoas abscess. Psoas abscess very important, right? Here, can you see the psoas abscess in here? Because I told you the both side the psoas muscle you can see, right? Don't confuse the kidney, right? Kidneys are different, okay? Here you can see the psoas abscess. Can you see the psoas muscles both here and here this side? You can see the psoas abscess, right? Here psoas abscess clearly. Here psoas abscess. Yeah, here initial CT showing the abscess with air fluid level a blunt in the left psoas muscle. Here the left psoas muscle. And you can see the yeah, here the area with the air fluid level as well in this abscess. Okay. Uh, okay, if you want, you can take a screenshot of this one and this one. Okay. Psoas abscess very important. Then psoas hematoma also given in e-medicine. So that's what I want to attach this one. 48-year-old man present to the GP with 2-day history of increase in lower back pain associated with the tingling sensation running down his left thigh. 3 days ago, he fell over and hurt back while gardening. Medical history includes the hypertension and atrial fibrillation, which he take pain refill and warfarin, right? Pain refill and warfarin. On examination, appear uncomfortable. Pulse rate is 90. BP 116 by 72, respiratory rate is 16, SpO2 98, temperature 37.2, unable to stand straight and more comfortable with hip flexion. There is some numbness over the anterior aspect of his left thigh, and the abdominal X-ray, CT is performed, and here given the hemoglobin 116, INR 4.2. Here, the psoas abscess. Can you see here? Sorry, not psoas abscess, psoas hematoma, not abscess here. This is the psoas muscle, right? Here, can you see? Yeah. Here. Okay, here why. CT may show the large left psoas hematoma, which is the correct diagnosis. Condition is known. Complications of this anticoagulation. I told you to focus that, right? Patient is taking the warfarin, right? Warfarin and what else? Yes, warfarin. Warfarin is taking warfarin. Usually in the retro. Sorry. 1 minute. Okay, okay, yeah. Have a sigh. Okay, INR for patients is history of warfarin-induced atrial fibrillation, subtherapeutic INR 4.2 contribute the risk of bleeding symptoms of back pain, hip flexion for the comfort and femoral nerve compression causing the numbness of the anterior thigh. Classic presentation of psoas hematoma. Very important, okay? Okay, then last I have attached the hydronephrosis because they have given a CT image in hydronephrosis in June exam, right? So what you can see, the hydronephrosis, right? You can see the dilatation of the renal pelvis, dilatation of calyces, right? Ballooning of the pelvic calyceal system. It depends on the stage of the hydronephrosis, right? So here you can see the hydronephrosis, right? The dilated, right? Here dilated of here, and the hydroureter, you can see hydronephrosis here. Can be associated with the hydroureter, right here. This is the picture they have given in e-medicine for hydronephrosis, right here. Okay, yeah, that's all for CT doctors. Yeah, and I hope you get the like overview idea about it. Overview idea about it. Is everything clear, doctors? Oh my God, finally finished the CT. I hope you had the better idea. I don't know whether you understood or not. I'm sure you have understand because I took a lot of time to prepare these slides and everything to teach you. Then I also got a lot of like a vast idea about the CD because at first I need to learn, then only I can teach you, right? Yeah, because of that. Okay. Doctor, I'll try. Okay, I'll finish this one, and if it is converting, I will do it. Otherwise, like I can't because I'm trying, still not yet solve this problem. Yeah. Okay, doctor. So I'm not sure tomorrow we can meet or not, but maybe next week I will give more priority for the August doctors. And I'm thinking of doing some camp, not the workshop kind of thing, but let's see. According to my time and schedule, if I can manage it, I'll do it. Okay. ECG I will do. I will do it next week. Okay. Next week I'm telling like other than ECG.